Let me introduce myself. I'm Dr. Ernest Kinoshi. I'm here on behalf of Clinix Health Group. And I think Clinix Health Group we are grateful for Clinix for sponsoring these webinars.
Dr. Kidoshi.
Yeah, we can't hear Dr. Kinoshi anymore.
I think we missed you there for a moment. Apologies, everybody. We're just having technical issues. Let's just give Dr. Kinoshi a moment, please.
My audio, is it audible now?
Yes,
I don't know.
Audible, Dr.
Yes,
Kinoshi.
we can hear you, Doc.
You may continue.
I can continue. All right. Thank
Yes.
you. That's right. So whilst our presenter presents, we will have you muted, but you may switch your you may we've switched your mics off, but you may put your questions and comments in the you may put your comments in the chat box at any one time. At the end, our speaker will address them. We'll also allow you, of course, to raise your electronic hands at the end during the questions and question and answer session. Just to let you know that if you have any queries, you may send us a message on webinars@clinix.co.za. Webinars@clinix.co.za. Our speaker today is Dr. Mmusa Modise. Dr. Mmusa Modise is an interventional radiologist of note, I must say. He is part of a practice that works within the Clinix hospitals. They run in about 5 hospitals as Doctors Mashao Dishausa Radiologists Incorporated. He's a director in the company, and they provide radiology services. He qualified with his MBSHP, of course, from the University of Pretoria, and got his MEd from SMU. It was still Medunsa at the time. And he also has a certificate from Turkey on peripheral embolization training that he went for at the site. His interests are in interventional radiology as a whole. I think about a year ago, he spoke to us on pulmonary embolism and his treatment. But today, his topic is prostate artery embolization. We will all know about it by the time he finishes, in case you don't have an idea what he's going to talk about. But it's quite interesting, very useful modality now these days. And I think Dr. Modise, over to you. I'll mute myself and you can continue. Over to you. All the best.
Thank you, Dr. Kinoshi. Thank you for the Clinix group for this opportunity to discuss an interesting subject, which we all know that with advancing technology and developments in medicine, most of the procedures are done with minimally invasive so that the patient can benefit with minimal invasive procedures, less invasive to get the same results as surgical procedures. Just before I start, I just want to make a short note of appreciation for the practice that I've joined over. I've been in the practice for 8 years now. Last year, we celebrated 20 years of this diagnostic radiology practice, which is called Dr. Mashao in Sichauya. We celebrated 20 years, and it's been a milestone with the two senior partners who have started the practice, which is under the name of Drs. Mashao and Sichauya. I just want to make a word of appreciation for giving me an opportunity to enjoy this practice. I've been in the practice for 8 years, and we have grown in leaps and bounds over a period of time. So today I'm presenting quite an interesting subject, which is very interesting because of the latest development, researches that are going around the world. We have traveled a lot, and we have seen the benefit of doing these procedures in this patient that present with common condition in the prostate. I've literally been doing these procedures for 8 years in the SK Matsika Hospital. There's a variety of procedures that I'm doing, which are minimally invasive endovascular procedures. So today, just a focus on prostate because November is a prostate month, and this is an opportunity to teach everyone and learn from everyone of this option of treatment for patients that present with obstructive uropathy conditions. Can we move to the next slide, please? So the most important thing that I want to emphasize is that interventional radiology as a super specialty in radiology, it entails collaboration with urologists or different specialties for different treatment that involves endovascular management. So all the patients are discussed, they are referred by urologists. So I just want to make a disclaimer that all my patients are not from GPs or they're not walking around the street. So this patient has to be worked up by urologist first, and this treatment option be offered to the patient as a mode of treatment. Next, please. So generally, there's a perception that the endovascular treatment that we offer to patients are new or trial or we are experimenting with patients. But I just want to make an emphasis that prostate artery embolization has been around for over more than 20 years. The first cases were done in Europe in 1977, and animal studies were done around 2008. And the first studies that were published by Prof. Carnevale in Portugal were in 2010. There are a lot of studies which have been produced indicating the efficacy of this study, of this procedure, which I'll share the number of studies that were done previously to show how this procedure benefit the patients. Next, please. So I just want to start with advantages of doing these procedures for patients. Like I highlighted initially, this is not an individualized or whereby we get patients walking into radiology and just do this procedure. These procedures are done with collaboration, whereby we discuss patients first and they get referred to us by a urologist as a treatment option for patients that present with BPH or obstructive uropathy. So advantages of doing this procedure as well published in the literature and in the databases that we have around the world is a minimally invasive procedure, firstly, which is very important, which minimizes open surgery for patients, is painless, which is comfort of the patient with minimal side effects as compared to open surgery or patients being exposed to open surgery. We just administer local anesthesia when we're about to perform these procedures. So we minimize the side effects of transurethral resection or open surgery that patients can be exposed to as an option for treatment for obstructive uropathy. And the good thing about this procedure is that patients benefit from immediate effect of doing this procedure, whereby symptoms improves immediately. Within 2 days post-procedure, you'll find that the patient can actually experience improvement relative to their symptoms that are presented with. And we have noted with literature and follow-up of these patients that the effects of these procedures are quite sustainable, whereby over a long period of time, patients improves and experience less symptoms. And with patients, because most of the time the patients are put on medication we know that as soon as we do this procedure, then the patient can stop or start reducing medication that are related to obstructive symptoms urologically. And with literature and with follow-up of these patients, we have seen that patients have improved erectile function, which is significant as compared to surgical procedures, and which is what patients look for, especially the elderly men that present to urology with obstructive symptoms. And added to that, we know that the advantage of doing this procedure as compared to surgical procedures, patients don't experience retrograde ejaculation, which is common with urological surgical procedures that are done for patients that present with obstructive uropathy secondary to BPH, which is benign hyperplasia of the prostate. Next, please. So the limitations of this procedure is that because of the studies that we have that are quite limited, we have not published yet the long-term results beyond 2 years. So most of the studies that were done were just limited to 2 years in terms of following up these patients that have done prostate artery embolization. Next. So indication for this procedure, commonly, as I have mentioned already, we want patients that are presenting with obstructive uropathy, which will present to urology, and they call them large symptoms. So symptomatic patients, moderate to severe, those are our clients. And we do what we call IPSS score, which I'll demonstrate on the next slides. Patients, we also do what we call QOL score, which is a quality of life assessment, whereby the patient obviously have nocturia. They go to the toilet many times. When they go to the toilet, they have got weak stream or difficulty in urinating. Patients that have been in medical treatment over a period of 6 months with no improvement, those are our clients. Preferably, we've seen that over a period of time that patients that have small volume of prostates, we tend to have technical difficulty in performing this procedure. So we recommend for urologists to send us the patients that have bigger prostate glands, preferably with a volume of more than 60 mils or 60 cc. So those are our clients. Patients that present to emergency units with acute urinary retention that requires urinary catheterization. So that those acute obstructive patients, those are our clients, because there's acute benefit of actually performing this procedure in these patients. The guys in Portugal have done a study which I personally think that it will beneficial for those patients, especially the ones that have prostate carcinoma and have done radiation therapy, that present with chronic prostatitis, which is a headache for urologists because they keep on administering systemic antibiotics to these patients with no improvement of symptoms. So those patients are targeted for us as well, because then we don't use what we call embolics, but we administer direct arterial antibiotics called imipenem. So patients that present with post-radiation prostatitis or patients with non-resolving chronic prostatitis, we offer them an option of treatment for this patient, whereby we don't use embolics, but we rather use direct intraarterial antibiotic administration. Next, please. So this is the table of IPSS score. When patients come through to me referred by urologists, we have this questionnaire for patients, because it's important for us to have a pre-procedure assessment of patients to the extent of the pathology that they have. So the main thing on this questionnaire is for us to be able to follow up these patients. You can see there they are numbered number 1 up to number 7. So we want to know if the patient can completely empty their bladders and how often that sensation of emptying occurs to them. And we want to know the frequency, so we score the frequency of how often they urinate. And with the third one is intermittency, whereby we want to know how often they actually feel like urinating, the time between where they feel like they need to urinate. Point number 4 is agency, so how often they found themselves in difficulty in postponing when they want to urinate. We want to assess how the strength of the stream when they go to the toilet, how often they have to when they experience weak stream. So we want to know from the patient that kind of assessment. And the sixth point, which is one of the assessment point, is how often they have to try and push or start urinating and they feel strain on doing that. And that's the last point of IPSS score, which is nocturia. So we want to know how often they go to the toilet at night, which is the most sensitive symptom that they experience, the patient that have obstructive uropathy. Next. So I just want to give a bit of background. The urologist colleagues know more about this pathophysiology as compared to me as a urologist, but of note is that we know that with male patients over the 50 years of age, up to 70% of them experience obstructive symptoms. And around the world, there's almost 1.4 million patients that are on medication because of this benign prostate hyperplasia every year. And we know that more than 400,000 patients are admitted in the hospital yearly because of symptoms, obstructive symptoms secondary to benign prostate hyperplasia. Next. So the pathogenesis, so there are two components that are responsible for symptoms of obstruction for this patient. We call it static component or dynamic component. So static component is related to the hyperplasia of the stroma, which leads to enlargement of the prostate gland, and the patient will present with obstructive symptoms secondary to urethral compression and obstructive symptoms. So the second point is dynamic symptoms, which is more sympathetic, is nerve system related symptoms, whereby the sympathetic nerve stimulation causes smooth muscle contraction within the prostate gland, with secondary urethral obstructive symptoms. Next. So, like I mentioned, the main indication for this procedure is benign prostate hyperplasia, so which develops primarily in the periurethral region or the transitional zone of the prostate gland. So, with BPH, we have what we call nodule. I'll demonstrate on the next slide on MR study, which is basically enlargement or development of the hyperplastic nodules in the transitional zone, which primarily comprises of stromal component and, to the lesser degree, epithelial cells, which contributes to the formation of the nodules in the prostate gland. So we know that patients that present with BPH, and hence the reason we do MR study in this patient before, so that we can exclude prostate carcinoma before we do this procedure, because the incidence of prostate carcinoma developing with BPH increases 2.29 folds with patients that present with BPH. Next. So this is the MR image that demonstrate, okay, I can move the cursor. Yes, that demonstrates. So generally when you look at the MR picture, we have what we call a peripheral zone where commonly we have development of prostate carcinoma. But this is the transitional zone, and there's a central zone which is not demonstrated in this image. But as you can see, I know it's a black and white picture, and I know it's a radiology image. Most of my colleagues don't actually understand what's happening here. But as you can see, we have mixture of signals there in the transitional zone. So these are BPH nodules because you can see that there's low or black image on the margins there. We call it a pseudocapsule. So these are the BPH nodules which I just mentioned on the previous slide. So this patient present with an enlarged prostate gland, but predominantly because of an enlarged transitional zone with BPH nodules. Next. So for the procedure, prostate embolization procedure, it's important to mention that there are contraindications for this procedure. Predominantly, when you do MR study, we want to exclude that the patient presented with malignancy, which is the main contraindication for PAE. Patients that develop with bladder diverticulum, we know that the results of doing PAE on them is quite not conducive for the patient, Patients that when we do pre-imaging for this patient, where we identify patient present with a bladder stone, we don't want to proceed until that bladder stone is being treated with, because then it won't be beneficial for the patient. Patients that present with neurogenic bladder is one of the major contraindications for this procedure. Chronic renal failure patients, because we administer contrast when we do this study, we can actually make the condition severe for the patients. Patients with acute urinary retention, whereby there's no improvement when there's a catheterization of these patients, we tend to avoid those patients because we know that the bladder function has deteriorated. Patients commonly, obviously, with infection, cystitis, we want patients to be treated first. Patients that present with bladder neck dysfunction, we also want to avoid those patients. Patients with coagulopathy condition, we want that to be resolved first, because then you will still see the patients having complications that are not related to the procedure, but related to the actual hematological condition. Urethral stricture definitely needs to be sorted out, because even if we do treatment to this patient, not resolving urethral stricture, they'll still present with symptoms that they came with initially. Next. So predictors of better clinical outcomes of this PAE, because we all know that patients, like I mentioned initially, patients that come to the hospital with obstructive uropathy, they are patients that are more than 50 years old. But we know that the older the patients get, the more they'll have enlarged prostate over 100 mils of 100 cc or 100 grams. Then those patients, we know that when we perform these procedures in them, then the outcome tend to be not that conducive or not favorable for the patient. So we always look at the age group of the patients that we actually treat with PAE. And we have seen with the studies that patients that do well post-procedure is patients that are around the age of 65 because of the lower IPSS score. And with lower IPSS baseline score, we know that the lower the score is, the more the benefit of this procedure. Whereas if the IPSS score is higher, we recommend that the patient go under surgical intervention. So patients who present with acute urinary retention tend to benefit quicker, because remember, like I said initially, within 2 days, you will actually see symptoms improving with this patient. This was done, I just quoted this was the outcome that was based on the study done by the Portugal group of Prof. Wilhelm, which was published in 2016, because he has noted that depending on those 4 factors that I've mentioned above, if you get the patient referred from the urologist, you need to look at those kind of things that actually improves or gives a better outcome for these patients. Next. So like I mentioned, urinary retention, acute urinary retention is one of the indicators for these patients. I know urologists tend to have difficulty in treating these patients when they present to emergency unit and patient presents with acute urinary retention. Then the casualty officer will put in the catheter. Then this patient have to stay with a catheter for quite a period of time. Carnevale have published a study which showed that with PAE, there's a 91% of patients that actually can be removed the catheter within 12 days period of time, which personally I think is one of the benefits of doing this procedure, rather than urologists waiting and doing TAP and still the catheter remaining in the patient. Whereas with this procedure, we can literally remove the catheter within a short period of time. Next. So in terms of the actual procedure, like I mentioned initially, before the patient get prepared for this procedure, we do what we call IPSS score and QOLA questionnaires, which actually help us to decide whether this patient will definitely benefit for this procedure or the surgical option for treatment. So these patients are referred to us by urologists, like I mentioned initially, and there's a urologist checkup that is prerequisited for us to look or to consider this patient for PAE. So we get the history from the urologist if they have done this procedure, like doing transurethral ultrasound to see how big is the prostate via ultrasound, do digital rectal exam to assess clinically how the prostate gland is, and take blood to do PSA levels, because the higher the PSA level, then we need to exclude malignancy. Do urodynamic studies to look at the actual bladder function, and do post-void residual volume as well. And if the MRI or there is a high suspicion of malignancy, then this patient will recommend they undergo biopsy first to exclude malignancy. Radiological exams, all patients that are referred for PAE from urologist, I do MRI to exclude malignancy. And pre-procedure, because most of the time you find that we have our patient group is patients that are elderly. I do CT angiogram of the pelvis to actually assess the pelvic vasculature to see, because those patients will be on chronic medication with vascular pathology, and we want to make sure that we're not gonna waste patients' time and compromise treatment by actually taking patients that we cannot cannulate the prostate artery. So we do assess the vasculature of the prostate gland before, but it's an optional. I know the guys that have done many of these studies, they actually just don't actually do an angiogram first before they do this procedure. They proceed and do a DSA in theater. But for me personally, it's important to do an CT angiogram of the pelvis to study the vasculature, the arterial system of the patient before the procedure. Next. So in terms of patient preparation and what we require for us to enable us to do this procedure. So one thing to point out is that one of the benefits of doing PA is that the patients don't have to go under general anesthesia as compared to open surgery or surgical procedures. So this procedure is definitely done under local anesthesia. I administer pre-embolization single antibiotic administration to prophylactically minimize infection. And if the patient present with a history of allergy, we do allergic prep before the procedure. And it's a painless procedure, so we basically just give prophylactic pain medication before the procedure. For us, technically, we put a Foley's catheter because we know that it assists us in terms of intra-procedure planning, because we know that when we have inflated the catheter with, we administer in terms of saline, which is generally done for urinary catheter, we put contrast in the catheter bulb, which assists us in terms of anatomical identification of where the actual bladder neck is and the prostate gland is. So in terms of access, there are two options. We rather do femoral or radial access. With development in terms of what interventional radiology have achieved over a period of time, we have tend to do most of endovascular procedure via radial access. So it's either we do what we call proximal radial or access or distal. I'm one fond of distal radius. I'm one of the few guys who actually do distal radius access, and I've trained my colleagues in terms of doing distal radial access because it has advantage in terms of hemostasis post-procedure. So we've moved away from doing femoral access. It's more of radial, and radial, like I said, you have two options. You can do proximal, you can do distal radius, and distal radius have more of benefits in terms of managing patient post-procedure. And with as much as I've mentioned that this procedure can be done with local anesthesia, so it gives us an advantage that these patients don't need actually to be admitted post-procedure. So if we do PAE in the morning with distal radial access, this patient can literally go home as soon as a few hours post-procedure, which is one of the advantages of this procedure. So in terms of preserving the access, we use what you call hydrophilic sheath, which is a 5 French. Is quite advantageous in terms of using this small sheath in the radial access. And we use for French catheter, guiding catheter, which helps us to get to the pelvic vasculature. And I use the catheter, the wire that assists us in terms of navigating the vasculature of the pelvic organs. We use a 0.035 hydrophilic wire. And before we do the embolization, we do an angiogram of the pelvic vessels. So there's a traditional or a advisable position of the X-ray tube or the cath lab machine tube position, which is actually 35 degrees on the same side of the prostate artery that you want to access with a 10 degrees cordial tilt of the tube. I'll show the classic image of what I'm describing at the moment. Next. So because of the size of the prostate gland, we tend to use, so basically the main catheter, which I mentioned initially, that it's a 4 French catheter, we use a 1.7 to 2.7 French micro catheter because the prostate arteries are quite small as compared to the women uterine arteries. So we super select the prostate vessels with smaller catheters, which are 1.7 French, and with a small, what you call micro wire, which is also hydrophilic. And we super select. So the most important thing with prostate gland to minimize what we call non-targeted embolization, we use cone beam CT. Cone beam CT is actually a software or a function of an X-ray machine in cath lab, which allows us to identify the soft tissue. I'll demonstrate on the next slide how cone beam CT images looks like. So the main thing about cone beam CT, it allows you, or it enhances, because then you'll have safe embolization, because you'll know exactly where the particles that you embolize go, because you would have injected contrast first to identify the prostatic tissue. So we use a pump that actually just inject a small volume of 3 cc of contrast with a very low rate of 0.1 cc's per second and with a 30 seconds delay, this is how we set up the angio pump to actually allow us to be able to do this cone beam CT. Cone beam CT enhances how we do the procedure. Like I said, it gives us an opportunity to do safe embolization. We don't use cone beam CT when we do big vessels like a splenic embolization, like when we do TACE for the liver or uterine embolization. But because prostate gland, the vessels are quite small in caliber, we tend for safety, we do this cone beam CT, which allows us to do safe embolization. I must say that it's quite exciting because we have these facilities in the Clinix group in SK Mateke, the angiosuit, the machine can do this cone beam CT. So because of the size of the prostate arteries, we tend to use a lot of vasodilators to enable us to see where actually we are radiologically. So I tend to use a lot of vasodilators. We call it isocad. We tend to use to administer small amount of it, 10 to 20 micrograms per vessel, to actually enable us to identify the prostate artery, or to make sure that we don't do non-targeted embolization. So the embolic agent that we use, the company, I've got a representative from company that I use, that is my supplier for this agent. Then we use a specific size for prostate artery embolization, which is 300 to 500 microgram size particles, embosphere particles that we use specifically for prostate artery embolization. As for uterine artery embolization, we use bigger particles because we have seen that the efficiency based on the studies and the databases that we have in interventional radiology. So the smaller particles, if I go down to 100 to 300, we have seen the adverse effects of non-targeted embolization if we use smaller particles. So throughout years, we have seen that the ideal size particle that can be used for prostate artery embolization is 300 to 500. Next. So intra-procedure challenges that interventional radiology is exposed to, which we all need to be aware of, is identification of feeders. We have seen that with older men who actually has underlying vascular pathology, they tend to have lots of collaterals or feeders that we need to be aware of when we do initial angiogram of the prostate, so that we can prevent non-targeted embolization. The most common non-targeted embolization that is well published, which is quite embarrassing for an interventional radiologist if you come across, is patients that develop penile ulcer. That's the most common one. But secondary to that, you can have rectal embolization, because I'll demonstrate on the anatomy later where the actual rectal vessels are positioned. You can also have bladder wall necrosis secondary to non-targeted embolization. So an IR needs to be aware of the structures that are surrounding the prostate gland that we need to be aware of. So through our time, we have developed many techniques to minimize this non-targeted embolization. So we use a lot of coils. So before we do embolization, we do a run to see if there are any collaterals. So if you see collaterals, before you embolize, you go to those collaterals, put coils there to make sure that your embolic material does not migrate to the area of non-interest. Next. So I just wanted to demonstrate. I know that we have mixture of colleagues in the platform. So this is just a photographic image of how a prostate gland looks. So like I said initially, all patients, we put a catheter in, which is demonstrated there with a bulb and a catheter there. So we inflate this catheter with contrast. So it helps us to identify, because we know next to the bulb, that's where the prostate gland is. And we super select, so this is a prostate artery. So it usually have what you call a central and a peripheral branch. So that's where we inject the embolics to make sure that we get good necrosis. Next. So I just want to make a point that the challenge that we face as interventional radiology is that the prostate gland, as compared to uterine artery, it tends to have many variants, which is a headache to us. But we know that 40% of the patients present with the two options there, which is the branch that starts from if you do an angiogram, I'll show on the next slide. So this is the superior vesicular artery, which supplies the bladder. And the blue one is a prostate artery embolization. So these two, A and B, are the most common two. So they make 40% of patients. So commonly we'll see these two branches, which the first one branches from the superior vesicular artery, and the second one branches from the anterior trunk. So if you do angiogram of the pelvis of the male patients, so we have a posterior trunk, we have the anterior trunk. So the anterior trunk, that's where we expect the prostate artery to branch from. So the first one comes from the superior vesicular. The second branch comes from the trunk directly. This first one is the most difficult one to cannulate. I'll demonstrate on the next slide. The third branch, which is about 10% of patients, they come from the obturator. Obturator artery classically depict the image of a fork. You can see with the two legs there. So sometimes we have a prostate artery branching from it. The fourth option is where it branches from the middle rectal artery. So middle rectal artery the rectum has three branches: superior, middle, and inferior. So the middle rectal usually comes from the anterior trunk as well. So you'll find that the prostate artery sometimes branches from that. The last option, which I've actually witnessed myself, is when we have what we call an accessory internal pedental artery. So naturally you'll have this internal pedental artery, which basically looks like a prostatic artery. They are usually parallel when you do angiogram. But in this instance, you find that the actual prostate artery comes from the accessory pedental. So some patients have this kind of variant. So it's important for interventional radiologists to be aware of all these possibilities. Next, please. So this table just shows the types that I just described. So it's actually 7 options, but the most common one is the first two. Like I said, the first one makes up to 27% of patients. That's what we commonly see as a variant, followed by the one that comes from the obturator, and this one comes from the inferior gluteal as well. So there are quite a number of varieties. So a radiologist needs to be aware of these variants because it's important. You don't want to be disorientated in terms of the vasculature of the prostate artery. Next. So this is what I see when I go to cath lab. So this is what we call DSA, digital subtraction angiogram. So like I mentioned initially, you can see there I've labeled the Foley's catheter. So this assists us as interventional radiologists because now you know that the vessel that just goes underneath or inferior to the Foley's catheter is actually a prostate artery. So normally, like I said, you can see that the prostate artery, which is depicted by the red star there, it branches from the actual, it comes out from the trunk. So this is a type 2, but a type 1 will come with a superior vesicular. So as there is superior vesicular artery, and you can see that there is an obturator artery. So if you follow it down, it gives you a fork appearance. You can see, as I mentioned, and the middle rectal is an R there. So it's quite small, but you find that with patients with a fourth variant, the prostate artery would definitely come from middle rectal artery. And so this is the internal pudendal artery, which is usually parallel to this. So when you start doing this procedure, you need to be able to identify the most common vessel, which is the operator. So anything above it is either prostate artery or superior vesicular artery. Next, please. So this is just another image which I wanted to demonstrate to everyone. Like I said, it looks like the internal pudendal artery because they are always parallel. So prostate artery has a tortuous kind of appearance. I'll demonstrate that on the next DSA image. Next. So this is a classic cannulation image of a prostate artery. So here you can see that the microcatheter is within the prostate artery trunk. So typically it gives us a tortuous kind of appearance or similar to the uterine artery, but we have a central branch and a peripheral branch. So it's important when you do this DSA to ensure that you actually see these tortuous vessels because the bladder superior vesicular artery just sitting next to it. Unfortunately, this patient, we're giving a lot of contrast. We're looking for the actual vessels. That is why there's contrast in the bladder there. But classically, the prostate artery will give you this kind of appearance. Tortuous vessels, triangular in shape. We don't want anything crossing the midline. We don't want anything crossing the pubic symphysis inferiorly, because if you see feeding enhancement going past the pubic symphysis, then you're most likely going to embolize the penile branches, which we don't want. That's one thing that we don't want the patient develop a penile ulcer. That will be a nightmare for an IR. Next, please. So this is a cone beam CT image. So like I said initially, we do a cone beam. So we put the catheter like I showed on the previous image. So before we start embolization, we do this cone beam CT, which definitely show that you can nicely see that the actual prostate gland is enhancing, which is just circled with the blue arrows there. Above the prostate is the bladder with the red arrows. So here the prostate gland is enhancing. So if we see that this is the left lobe of the prostate gland actually taking up contrast, then we know that we're safe to embolize. So we do a cone beam CT. So this is an image of a cone beam CT before actual embolization. Next. So I just wanted to demonstrate to everyone what we look for and what we want to achieve. So on the images before, I demonstrated that this is the kind of image on the left side. So the big vessel that you see there, it actually supplies the transitional zone of interest with blood. So prostate artery usually have two branches, which we call the central and the peripheral. The central is the one that goes horizontally It supplies the transitional zone, but we make sure that we embolize both of them because this one will supply the apical segment of the prostate gland. So this is the base of the prostate gland above, close to the inflated urinary catheter. And here is the base of the prostate gland. So these are the two vessels of interest that we need to embolize. And on the right side, you can see that that's post-embolization near stasis image, where you can actually see that those vessels are not really filling because we have embolized them. Next image. So on this table, I just wanted to emphasize that there are a lot of studies that were done on PAE, and they were done on different parts of the world. My slide is quite cut off there, but the first study was done in 2021. The study above it was done in 2021, 2026 in different parts of the world. So this table just shows us how much volume of study have been done. And this study was done over 810 patients in different parts of Europe. And the study was comprised of comparing surgical PAE to surgical TAP or open prostatectomy. And here is just a table to show the results. And it was noted that with PAE, patients tend to have less side effects, quicker recovery. Patients don't experience there's quite improvement in erectile function of these patients, which is quite significant to male patients, and patients don't experience retrograde ejaculation as compared to open surgery. So with this slide, I just wanted to point that a lot has been done, as much as the society out there and the colleagues, the clinical colleagues have the perception that PAE is a new study. It has been around for quite a while. There are a lot of studies that have been done with this procedure. Next, please. So this is just, like I mentioned, 7 studies, table compiled with comparison, which the data has demonstrated the significance of doing these procedures for patients that present with BPH. Next. So complications that can happen, obviously, we can have non-targeted embolization. Patients will present with rectal bleeding. Patient may present with hematuria, which we have seen with patients few days post-procedure. Patients can present with infection, but we do give antibiotics, preload patients with antibiotics to minimize complication. Patients can present with urinary retention or bladder ischemia secondary to non-targeted. So all complications are related to non-targeted embolization, and we have developed mechanisms to make sure of minimizing complications and make sure of safe embolization for these patients. Next. So just to put a pointer, I know my urologist colleagues always want to make sure that everyone is aware of what they do for these patients. But these are the options. The patients can undergo medical treatment with alpha blockers and drugs that are listed below. The most common procedure that urologists do for this patient is TAP, which is common in South Africa. Other countries do Urolift. Laser is quite famous as well these days. So these are the treatment options, surgical treatment options that we all are aware of that are offered for this patient. So I just wanted to elaborate that we're not saying we're taking over BPH treatment. There's still this option, but patients are referred to us as a treatment option. Next. So just in summary, in terms of what I actually do in Dr. S.K. Mazike Hospital, I just want to make an emphasis that the main treatment that we have actually is the main procedure that we do in cath lab at SK. I commonly do uterine artery embolization on a weekly basis. Up to so far, we have done over 700 cases with 99% success rate, and which I'm quite excited about. And I'm hoping with time that we'll reach this number with PAE with old men that are presenting with obstructive symptoms. that will be referred by my urologist colleagues so that we can assist them and minimize complications and give them a treatment option. The second arterial procedures that I do is TACE, which is actually transarterial chemo embolization for patients who present with hepatocellular carcinoma or adenocarcinoma metastasis to the liver. We have done quite a number of these patients. I've done a lot of patients for renal artery embolization that were post-traumatic or post-biopsy complications, or patients that present with diagnosed renal angiomyolipomas. They benefit from renal artery embolization. Patients, we know our community suffers with PTB, long-term complications of pulmonary TBs, hemoptysis. We can do bronchial embolizations for them. I've done quite a number of patients that present with gastrointestinal bleeding, specifically proximal GIT bleeding, splenic embo for patients with present with hypersplenism. I've done quite a number of patients with internal hemorrhoids. My surgical colleagues are not happy with that because I'm minimizing their hemorrhoids treatment. On the arterial side as well, I've done MSK patients that present with grade 2 and grade 3 osteoarthritis. We assist them with, it's not complete embolization, but partial embolization to minimize knee pain. And there are other MSK joints that we can do temporary embolization, which is frozen shoulder, tennis elbow, Achilles tendinosis, and plantar fasciitis. So interventional radiology is expanding into musculoskeletal embolization. Venous work, I've treated patients with pelvic congestion syndrome, which is a headache for gynecologists because there's no medical treatment for that. We do coil embolizations of the spermatic or ovarian veins to improve the pelvic congestion syndrome symptoms. Last year, we have started a project 2 years ago. I've presented in this platform treatment of pulmonary embolism, which is thrombolysis called ECHOS. We've done male treatment as well with varicocele, same as pelvic congestion syndrome, whereby we embolize the spermatic veins to help with improvement of pain related to varicocele. Symptom improvement. We treat DVT as well with ECHOS treatment. I've done IVC filter and removal of IVC filters in our setting at SK Mateke. Next, please. Yeah, that's the list of reference. That's my last slide. I've stayed for 55 minutes. I just want to give 5 minutes to the company called Merit Medical, which they actually provide. They give me lots of tools that I use for my procedures. So I just want to give them 5 minutes so that they can give an overview of what they supply, which I think is important for us to be orientated as well. But before they take over, I'll take questions after my colleague has presented. I just want to say thank you to, I've got good relationships with the urology team in the clinics, Prof. Mtambuira at September, Dr. Ekanem at Lesedi, Dr. Madlala at Botsilong Hospital, Dr. Sillo, my favorite guy at Naledin Kanyezi. We have worked together so well, and I'm hoping with time, we don't have data in South Africa when it comes to PAE. And my wish and my hope is that throughout time, we'll be able to have our own local data of number of patients that have underwent PAE, so that we can be able to share the database with the international community. Because at the moment, we're just using the data from Europe and Asia and America, which we rely on. And I think with time, we really need to produce data from our side, and it can only come from collaboration with clinicians to enable us to produce data. This procedure is done in the government settings locally. We struggle to get authorizations with medical aids, but Discovery is playing game. So with time, hopefully, the same as UFE. I mean, UFE has been around, and the medical aid are playing game lately. there's no medical aid that's resistant for us to authorize. Hence, my numbers are quite high when it comes to UFE. So I'm hopeful that with time that PAE will be standard, or it will be a good option for treatment with patients that have chronic prostatitis or BPH. I thank you.
Great, Dr. Modise. I think before we give everyone an opportunity to make comments or ask questions, let's give Mr. Philip Shilobo. Mr. Philip Shilobo is from Merit Medicals. I think that's the company that Dr. Modise was talking about that provides the embosphere particles and the catheters and the wires that you use. Mr. Shilobo, are you on? You can see a lot of applauses all around Dr. Modise.
Thank you.
Okay, you can put your camera on. Sam, you can let Mr. Shilabo say a few words. Dr. Modise?
Yes, Doc.
Yeah, I see Mr. Shilabo is not talking. He was in the meeting. Sam, are you able to see him in the list? You can unmute him, assist him in unmuting.
Oh, he just texted me that you need to unmute him.
Yeah, Sam, please do. He's in as Philip Shilobo, am I right?
That's correct, Doc.
Yeah. Yeah, otherwise we'll have to skip him. Sam, can you see him? Otolakele? Oh, that's a pity, but I think let's give colleagues an opportunity to ask questions and I think at the end, Dr. Modise, if you want to put your number in the chat group for people to contact you if they would like to, I think that will be in order. You can just put your contact details in the chat group for anyone who would like to contact you after this. But I think this was wonderful. But let's take a few questions whilst we wait for Mr. Shilobo if he wants to say a few words, because I think that's the company that Dr. Modise works with very closely. And I'm glad, Dr. Modise, that you mentioned working with urologists. I think that's great. But let's take the first question. I think the first question is from yes.
Sorry, he's on.
Is he on? Okay.
Yes.
Then he can talk. I'll just mute myself briefly. We'll give you a few.
Okay. Good afternoon. Or good evening, rather. Sorry. My name is Philip. I'm from Merit, and I see the time has already gone. So I'm just going to give
you can put your camera on if you like.
No, it's fine.
That's fine. Okay, go ahead.
So my name is Philip and I'm from Merit Medical. So I'm just going to give you a brief overview of what we provide to Dr. Modise with all the procedures that we do. So I actually had a presentation, but I think it's going to take a long time, and I say it's already late. So we're based in Lanseria, first of all. We are an American-based company, which I know a lot of people don't want to hear right now, but yeah. We currently provide Dr. Modise with the embolics, hydrophilic wires, which mostly work in either urology and interventional radiology. But we also do have other portfolios. We also have our Merit Oncology portfolio, which covers the likes of your Scout and other stuff. So I can't do a presentation right now because I see the time is already gone. It was taken by muting and unmuting. But yeah, thank you so much for the opportunity.
Thank you very much, Mr. Mrs. Shiloba. I see Dr. Sididza has got two questions, actually. He says, what is the incidence of chronic prostatitis post PAE, Dr. Modise? And his second question is intravenous imipenem still a treatment of option once one has had a PAE procedure done? Prostatic artery embolization.
Okay, thank you for the question. Just to address the first question, we don't really see a lot of post-infective prostatitis post-UAE, but actually, like I mentioned on my presentation, there's a group in Portugal now that have actually done a study whereby they actually treat patients with chronic prostatitis where they do PAE but not using embolics, but using intravenous imipenem. Patients that are post-radiation, patients that have chronic prostatitis not responding to systemic antibiotic, and PAE not necessarily using embolics, but using intravenous imipenem, which actually crystallize, because even for osteoarthritis, there's an option of using temporary embo, which is imipenem, to actually alleviate knee pain. So post-procedure, we don't see a lot of chronic prostatitis because we pre-load them with antibiotics. We don't get a lot of infections, same as UFE patients. There is a small number of patients that actually experienced infection post. Is less than 1% generally. So instead of us treating or experiencing post-infective changes with PAE, we actually use PAE to treat chronic prostatitis commonly related to radiation.
Thank you very much. Dr. Mukhali, Dr. Daniel Mukhali is asking, I see there's a question from Professor Mutambira. We'll take it just now. We'll come back to you, Prof. Dr. Mukhali says, how come we have what we call long-term follow-ups of only 2 years, whereas the procedure has been there for over 20 years? Surely we can trace those who had this procedure before?
Yes, thank you for that question. It's quite an interesting question. And I think the issue is that patients tend to, which I've seen with UFE patients, I've been doing UFE patients for the last 10 years at Lesedi. So you find that you enroll patients into a study, and once symptoms improve, like with the studies that I've mentioned, they actually do 6 months, 12 months, 18 months, and 24 months follow-up. But you find that patients have symptom improve and they don't see the need to actually do long-term follow-ups or come back to the hospital for any kind of reason. So I think that's one of the limitation when it comes to our procedure, because patients get immediate relief or immediate improvement. So if we enroll them to a study, then you have those kind of challenges to keep on calling them to come back. But I think with a period of time, like I said, we need to collect data. I mean, data is the only definition of evidence-based medicine. And I believe that with time, locally as well, we'll need to be able to produce those long-term databases. I mean, the latest article that was released for 2024, which was a meta-analysis of different studies, you will see that there's no patients that were actually followed up beyond 2 years. And the challenge of that, then, it gives the perceptions that surgical interventions are much better than PAE. But if we can have data that actually gives us the room to follow up patients over a longer period of time, we'll be able to convince the clinical groups that PAE works better. So I think we need to contribute to the database society. I think that's the message.
Great, thanks for that response, Dr. Modise. Let's go to the hand of Professor Mutambira. Sam, can you unmute Professor Mutambira?
Prof, please don't corner me.
Sam, are you winning? Prof, you can unmute yourself.
Thank
you.
you.
Yes, you can go. You can go ahead, Prof. Go ahead.
Thanks. Great talk, Mmusa. And I do appreciate what you've been discussing. It's really such a great topic. And I think one of the things that we're talking about now is that a lot of the times when we're using medications, if you look at the cost benefit analysis, it could be more expensive to keep using medications for 30, 40 years rather than getting something like this done. I know we're not in conflict. I just wanted to ask two quick questions. First of all, we know there's a lot of fluoroscopy there. We're very worried about the amount of radiation that we give. How much is it, and how worried are you about that? And then the second one, you said that you shouldn't use it for prostate cancers, but there is some data about patients being using PAE for prostate cancers as well. So I just wanted your comments on that. But a great talk, thank you, and thanks, Prof. Kanachi, for sharing this so nicely.
Well, I'm not professor yet.
Okay.
Thanks, Prof.
Thank you,
Thanks,
Prof.
Prof.
Thank you.
Thank you very much. But you can go ahead, Dr. Modise.
Yes, Prof, I'm glad that you asked those two questions, and I know you are quite scientific. Just to answer the first question, we don't, because we actually don't expose patients to too much radiation because of the softwares that we have now with the cath lab machines. We do a lot of coning, and actually the actual cone beam CT itself, it doesn't utilize a lot of radiation. So patients are not quite, it's not like doing a neuro patient. They are not exposed to a lot of radiation. There is techniques to minimize radiations, like I'm saying. We have softwares which we call endovascular guides, whereby once you have done a run for a pelvis, you can actually map, you use a software to actually see where the prostate artery is. Then it minimizes the actual runs that you're doing so that you minimize radiation to the patient. And the cone beam CT as well, like I said, it actually helps with assisting with safe embolization. So you don't have to do a lot of runs to exclude confusion where you are in that. So basically, you do few runs, Prof. We do a lot of coning, and we use a lot of software to actually guide us in terms of accessing the artery. In terms of research, I just like what you said. Actually, I was in Japan a month ago for MSK Embo, and there's a prof from Germany who actually has done a study in doing prostate PAE for patients that present with cancer actually, and it has actually demonstrated good results. So there are two options. So what he has done is he has done a study with doing cryoablation, which basically involves freezing of the actual prostate tumors themselves. So he does embolization for the patients that present with cancer and do cryoablation. So cryoablation is predominantly done for patients with renal RCC, renal tumors, and patients that present with liver tumors or lung tumors. But he has moved and used cryoablation as well for patients that present with prostate CA to treat them. And it's an amazing kind of study, I must say. So, and just to add on top of that, as much as we use embolics, there's a Portugal group as well that they're using glue to actually do embolization instead of embolics, which shows positive results as well. So there's a lot of studies and procedures that are done for BPH and prostate carcinoma, I must say. Like I mentioned, for CA prostate now, there's EMBO, there's cryo, which shows good results. And for BPH, they're using glue, they're using embolics for treatment of this patient. So in a long-term run, data will actually demonstrate that Prof. Ntambuira doesn't need to take these patients to theater, he rather refers them to me.
Yeah. Thank you very much. I think Dr. Reina Abram is asking a question. What do current data show about durability of symptom relief after PAE? I think it's another way of saying for how long do the symptoms disappear? With the chances of recurrence?
Thank you very much. Actually, there's a paper that was released from the Portugal group last year. So, which actually shows, I don't know if the doc missed my point initially. So, we get immediate relief. So, patients get symptoms relief within 2 days post-procedure. But with the follow-ups, like I said, the limitations is up to 2 years now. But with the patients that have been followed up with the PAE, we have seen that if you look at the actual graph, there are two things that improves. Patients tend to have symptoms relief. You can actually remove the catheter within 12 days with the one patients that present with obstructive uropathy. And because with PAE, there's necrosis of those BPH nodules, there is increased progression in terms of symptoms improvement. And patients have reported as well improvement in erectile function, which is commonly important to males, which is a sort of a negative when it comes to surgical procedures. So there's a prolonged or sustained improvement in terms of symptoms for these patients.
Great. Is there any chance of recurrence of the symptoms after many years? You know, you do it with the particles, and is there any chance of revascularization of the prostate?
Dr. Kenos, there's always chances of revascularization, right? But what we have seen is that there's a study that actually compared unilateral prostate artery embolization and bilateral prostate artery embolization. And because of the patients, the kind of patients that we cater, you find that patients have vasculopathy or underlying disease, and then you tend to embolize one side. So if you embolize one side, then you increase chances of collateral formation or revascularization. But we have seen that if you do bilateral embolization, possibly, it's not all patients that they are able to do bilateral, but if you are able to do bilateral embolization, then you minimize chances of collateral formation or revascularization. And I've seen with patients that have done UFE, I've done UFEs for almost 10 years in the practice. I had few patients that actually came back with new development of fibroids. So to me, logically, with prostate, as much as we don't have much data as compared to fibroids, I expect the similar results.
Yeah, I think it's Dr. Isaac Kosa is asking, do you mean you're doing this procedure under GA? I know you mentioned that you said that you don't do it under GA. I think you
Yes.
sound
It's
surprised
like
that
it's
you don't
local
do it under
anesthesia.
GA. That's right. Yeah. So you are confirming that each time it's all under local anesthesia.
Yeah, can I just add, Dr. Gnoshi? So the main
Yeah.
thing is that this is an alternative treatment for urologists. Like I started by making a disclaimer. So we're not taking away patients from urologists, but we're saying patients that have comorbidities that are not fit for anesthesia, the ones that you know that if this one will give anesthesia is going to have problems, the one with large prostate volume of more than 60 cc's, those are the kind of patients that I recommend urologists to send to us because the procedure is done under local anesthesia.
So you always, for each patient, you work in conjunction with the urologist, I suppose.
Yes, all of them are referred by urologist, doc.
Yeah, and they can be done on an outpatient day hospital procedure?
Yes, that's correct.
That's great. Somebody's asking about, I think it's Dr. Vusi Memela. He says, what does the RSA limited data, I don't know, maybe there's something wrong with the question. What does the RSA limited data indicate so far as compared to UK? I'm reading it as it's written. And in other words, our data in South Africa compared to those of in the UK?
Yes, like I said initially, there's no much data as compared to local data when it comes to this procedure. I mean, the Pretoria group have done a study on UFE. So locally, we have done more studies on UFE as compared to prostate. There's no paper that is locally produced in terms of PAE. So the whole purpose of us or me presenting at this point in time in the November month is for us to start, sensitizing people of this option of treatment so that over a period of time, we can have a combination of government and private combining the data that we can actually produce and write articles on. Unfortunately, we're relying on American and European data at the moment.
Yeah, I see someone is asking a question, Ms. Gloria or Dr. Gloria Muruput, whether there's an attendance register. I think you signed the attendance register when you registered to receive the Zoom link. So those who have who have logged in now, not having been given the Zoom link secondhand from somebody who's registered. Yes, it's good that you can attend, but the HPCSA will not credit your profile with CPD points if you have not registered yourself. When you register, it takes only 2 minutes. Those who've registered know. You just fill in your name, where you come from, whether under which clinical discipline or you are registered under, and also whether it's MDP or whether you're any other registered health professional, and your number. I think the most critical thing is the HPCSA number in the case of HPCSA. Of course, nurses with a SANC number can also register. Pharmacists can register with their pharmacy number, pharmacy council number. But that's more important. You don't register with your some people have a problem because they use their BHF practice number, which won't work to get CPD points. You need to use your HPCSA number, just to answer that question that's in the chat group. But there's another question from Dr. Itimele Mutloing saying, what material are these embolics made of, Dr. Modise? I think you spoke about embosphere particles that you use. What are they made of?
Simple answer, they are gelatin. They are made of gelatin. So gelatin is more like a meat product. So over a period of time, they get absorbed by the body, but they are predominantly made of gelatin. And we have used gelatin over 100 years of actually embolizing many structures in the body. I mean, even for a simple renal biopsy, we still use gelatin to block vessels. So it's gelatin product.
Thank you. I hope you answered. But Dr. Mabel Kikana is saying she's concerned that there's so much minimum research in this area when you are doing so much beautiful work. And she says maybe you can consider collaborating with an academic institution, academic department, so that formal research can be conducted and published. How would you answer that? How do you
No, that's
respond?
correct. Yes, like I pointed out earlier, most of the data that we're using, unfortunately, is an American and based data. So it will be wonderful to have local data. Like I said, mentioned initially, I mean, the Pretoria group, it was a collaboration between private and public setting, where they produced a paper based on follow-up of EFE patients. So PAE is quite wonderful. I'm very passionate about it, as same as musculoskeletal. So collaboration with academic institution is the way to go, so that we can publish local data and convince medical aids. I think that's one of the main reasons why we need to do research and publish data on this procedure.
Well, Professor Mutambira is in the room, he's listening.
Hey, Prof, keep quiet.
Thank you very much. I think that's a list of questions I can see, unless if I'm missing any in the chat group, Sam in the background. But I think this has been a wonderful evening. Dr. Modise, I've asked my colleague, Dr. Burton, Shinas Burton, to just thank you formally. Dr. Burton is Dr. Burton Shinas. He is Chief Medical Officer within Clinix Health Group. Sam, you can just unmute him.
Hey, Dr. Modise, how are you today?
I'm all right. Dr. Burton, can I say something? Can I tell Dr. Kinoshi something?
You better not do that. You're on a public platform and many of my colleagues are listening. So
I was in the same race with this gentleman in medical school. I'm gonna stop there.
Yeah,
Don't tell us your secrets.
Yeah, exactly. I was just about to expose you too, Dr. Modise. I thought we're gonna expand a little bit more, so let's leave it at that. But
yeah, let's leave it there.
I can tell you, I am so proud. I'm so proud to see you this evening as you are presenting and information is just flowing. And In your expertise. I mean, when we bumped into each other at SK a few months ago, you remember we just looked at each other and we were speechless. And
Yeah.
I'm so proud that you eventually got to do the presentation. And yeah, it's excellent as was expected. And you no doubt shared great insights from various angles and perspectives. And I can assure you that there are hundreds of your colleagues that are on here from different disciplines that are totally enthralled and were gripped as you were going through the presentation. Sometimes you think these concepts are quite complex, as you know from med school, some of the professors, and they didn't always teach you the information, but you were able to pass it on and simplify it that we can log off later and understand it and apply it to some form of degree. So thank you for taking the time and putting this presentation together. And please thank your family. I hope your supper is waiting for you, and it's going to be nice and hot when you are done here. So thanks for that.
Hopefully.
They've eaten it. So no, thank you to all our colleagues as well for your presentation, participation every single time that we are meeting you on Thursdays. And it's really encouraging. It's inspiring for the presenters as well that you continue to applaud. If you saw Dr. Modise, all the hands clapping and wishing you well. So thank you to everybody for encouraging and inspiring one another. And we want to continue to welcome you to put up your names. Prof, you were bold enough to come on. You didn't put your camera on, so we expect the presentation from you soon. And then, of course, Dr. Kinoshi, who's always diligent and he loves this platform as well. And he's really committed to ensuring that education continues for us as health professionals in the country, to ensure that our standards are remarkable. Dr. Modise, really still, I can't check how excellent it was. And to see how you once were to where you are today, and I can imagine where you're still going.
Now you're starting.
Then to the Clinix Health Group, behind the scenes, there are some of our colleagues, Tolakele, Aviwe comes on, Sam. Thank you so much to you for your professionalism and making sure the presentations go smoothly, and to Clinix Health Group for sponsoring these events. We want to say thank you so much for making them available to us free of charge, and we look forward to seeing you again next week. Thank you so much, Dr. Kinoshe.